And we're rolling.
Alrighty, I'm going to be starting off this evening by talking about treatment options for veterans with post-traumatic stress disorder. And we're also going to be talking about traumatic brain injury, the different levels of traumatic brain injury. So as you're assessing people and they mention the fact that they've had a traumatic brain injury, that you can kind of ask additional screening questions to help determine which type of traumatic brain injury they've had. So I guess, Simone, are you advancing this or am I?
I will do it.
Okay. So tonight, what we're going to talk about when we get to it is we're going to briefly discuss some traditional PTSD therapies such as cognitive behavioral therapy, prolonged exposure therapy, EMDR, which has been found to be particularly helpful for processing trauma in veterans and just trauma in general, and what medications would be useful to decrease the symptomology in veterans. With that particular piece, to keep in mind that it isn't so much an attempt to make the symptomology go completely away, but as opposed to making it a maladaptive response to the experience of war, to essentially allow the individual to find their way to make sense out of the trauma. So once a person goes to war and comes back from war, they're not the same person as they were when they went. And our job, if we're working with veterans, is to help that person be as successful as possible. Hush, Coleman. Given the fact that they have changed, having been to war. We're going to talk again about the criteria about mild to moderate TBI, and we're going to highlight recommendations for initial interview and alternative therapies such as yoga, Tai Chi, breathing-based meditation, logotherapy for adjunctive PTSD therapy. Now, a lot of this material came out of an article that I wrote with Randy Moore and another faculty member about 2 years ago. That's one of the readings posted. So for more details, it's listed in there. Next slide, please. So to begin with tonight, we're going to talk about a case study up front, because last week we introduced all of the criteria for PTSD, but in tonight's scenario, we're looking at PTSD specifically related to veterans and how it might be different than someone who has had a single exposure to a trauma. So our case study tonight, our specialist is Specialist Gomez, who's a 22-year-old infantryman who was brought to the combat stress control following an incident in which he was found by hospital staff choking a middle-aged Iraqi man who was also convalescing in the same hospital ward at the Air Force Theater Hospital in northern Iraq. One of the things to keep in mind in a Air Force Theater Hospital is that unlike your experience in hospitals in the United States, where patient privacy is of the utmost, in which everybody has their own single room, this hospital theater may be one big tent with cots set up in the tent, in which everyone is kind of in a main bay. So there is not a whole lot of privacy in such a place. Now, I'm not sure how this particular theater hospital was set up, but that's something to keep in mind, that it is not like a civilian hospital in which everybody's got their own room. So what I'd like to have you consider as I'm going through this is, what symptoms do you see that are going to help support the diagnosis of PTSD? So as I go through this, think about that. When I get to the end of this particular slide, I'd like some feedback in terms of what did you notice in this section of the case scenario. So at this time, he's serving his second combat tour of duty and had just been injured in the fifth IED explosion he had personally experienced as a member of a 5-man team out on patrol. One team member was killed outright, another team member, subsequently died of the injuries he sustained, and 2 other team members sustained major injuries, including severed limbs. Specialist Gomez was not sure why he survived, and he sustained only minor contusions and ruptured eardrums. So, given this particular information, what do you notice so far about this particular scenario? Does the criteria of exposure to trauma, yes, thank you very much. And this fellow had repeated exposure to trauma. And I see, if I scroll up just a little bit here, Sabina commented direct exposure to trauma. I don't know that anything said so far says anything about flashbacks yet. Survivor's guilt is certainly something that one would wonder about, considering of his team, he's the only one who came away unscathed. So next slide, please. So on initial interview at the Combat Stress Control, he describes flashbacks that he was having of the recent explosion, even though he was also having difficulty remembering certain events. He had been in the Air Force Theater Hospital for 2 days, but he was just beginning to come to terms with that. He had asked hospital staff to move him to a different ward because he was afraid he might injure someone because of the anger, rage, and guilt at being alive that he was experiencing. He related how he was having great difficulty in distinguishing who was and who was not the enemy. Bed space was limited in the hospital, and he could not be moved to another area. So given this much more information, what is it that you notice about this? Derealization, okay. Flashbacks. Difficulty remembering certain events. He was involved in an explosion, so as we get looking at the criteria for TBI, he may also meet criteria for the TBI. Hush, Coleman. Hypervigilance. Thank you very much on that particular one. He also may have been experiencing something called a problem with contextualization, in which he couldn't distinguish between what was going on now and what was going on when he was actually engaging the enemy. So contextualization, not being able to tell where things fit given his pieces of information. Next slide, please. So upon return home 4 months later, Specialist Gomez sought a referral to the mental health clinic at his Army base because he was constantly irritable and having difficulties in his relationship with his fiancée, with whom he was living. She was upset with his tendencies to become easily startled by the smallest thing and his inability to relax and not be on guard all the time. She felt he was not the same man with whom she'd fallen in love, and she was displeased with his being constantly moody and distant. He no longer was excited about the plans to marry and start a family that they had made prior to his most recent deployment. So what are you noticing here, given this additional piece of information? If you got a microphone and want to use it, it would be cool. Irritability and negative affect. Okay, thank you. He's feeling detached from others. Thank you, Karen. Inability to connect with others. Okay. With his no longer being excited about plans to marry, it's not unusual in startle response. Thank you. It's not unusual that people have what is called a foreshortened future, in which it's difficult for them to look forward to events in the future because they don't necessarily see that they have any future or much of a future at all. And anhedonia, imagine that you could probably read that in here. probably by the fact he was no longer excited about plans to marry. But I would attribute the no longer excited about plans to marry and start a family has to do also with his foreshortened future, where he doesn't necessarily feel like he has much of a future. Hush, Coleman. Next slide, please. So Specialist Gomez also described difficulties he was having going to and staying asleep. He stated that he seldom slept more than 2 or 3 hours, even after drinking a fifth of liquor. Also, he realized there was nothing he could do to stop the combat-related nightmares he experienced on a nightly basis. He was having intrusive thoughts of his combat experience many times per day, but he had been having difficulty remembering certain events and places he had been while in Iraq. He has avoided most social events, including a unit cookout, as the smell of grilling hamburgers reminded him of the burning flesh he'd smelt while in Iraq. Now, with this particular part of the scenario, you'll notice that his avoidance here around a social event was not necessarily to avoid crowds, but because he anticipated that the grilling hamburgers reminded him of the burning flesh he'd smelled while in Iraq. So when you're looking at avoidance, look at what purpose the avoidance is having in terms of avoiding being re-triggered to the very events that has started the PTSD. So what other things are you noticing in this part of the scenario? Coleman, you're going to have to get out.
Yeah, y'all are definitely mentioning the sleep issue, which is, I don't know if I've worked with anyone who had PTSD who did not have a significant issue with sleep. I don't know if it's been a similar experience that y'all have noticed, but that alteration in arousal and just that general state of hyperarousal sleep is indistinguishable, even for people who aren't having nightmares. Because some folks will avoid sleep because the nightmares are so bad. I don't want to go to bed because I'm going to have another nightmare. And then they'll be miserable because they'll be completely reactivated. And that's a lot of alcohol. That's a good.
It is not uncommon, however, for individuals to attempt to drink themselves into a state of complete numbness. And so a fifth of liquor is an incredible amount of alcohol. But this fellow's noting that even after drinking that much, he still was having the nightmares. So what other things do you notice in particular in this particular part of the scenario beyond what we've just talked about? Is there anything else? Okay, Karen, intrusive thoughts, thank you. And difficulty remembering.
Mm-hmm.
So there's some cognitive impairment, perhaps. Okay. Any other thoughts from folks? All right, let's go on to the next slide. That's the end of that particular one. With this particular fellow, what kind of a care plan would you come up with for him, looking at both what you know of therapy as well as what medication you might use? Okay, prazosin, Zoloft, EMDR, and prazosin, CBT, and sertraline. Okay, so we've got CBT and prazosin, trazodone, Jeannie says for sleep, I suspect. So let's start at the top with what would be your first target symptom that you would look to see if you could find him some relief? Where would you start? So Jeannie would start with sleep. It looks like most people identified sleep as the primary place to begin. Karen said detox. One of the things that you don't know at this point is that was that a one-time extreme case that he drank a fifth of liquor with hope of finding some relief? But additional assessment it would be needed there around his alcohol use. I'm in agreement with that particular piece. So we would start by looking at getting this fellow a little more sleep. So what would be your drug of choice and what dose would you begin with? All right, Jeannie would begin with 1 milligram of prazosin. Anyone else?
Would there be a medication for PTSD that if you want to look at more than one bird with one stone, would there be a better choice? Sure, mirtazapine, that can help. FDA indicated drugs for PTSD. Not that you always are limited to FDA, but right. How would Paxil be superior to Zoloft in one particular way? There you go. Yeah, exactly. So say you have somebody who, I don't want to take any medicine, but maybe you can talk me into taking one thing. So, and I'm not sleeping and I'm irritable and I'm depressed. So what can you do? Then that may be the better choice for a real edgy, anxious, amped up, can't sleep guy who doesn't want to take more than one drug.
Yeah, and with this particular fellow, he's still on active duty, so he's probably going to be somewhat resistant to taking pills, which would make him, which would relate to being sick when people on active duty resist pills a lot of times because they don't want to appear that they're sick. So he may or may not go with medication, and it's something to consider. Hush, Coleman. With it, sometimes people on active duty, because they worry about their security clearance, because sometimes getting started on medicine for treatment of PTSD or underlying other disorders may jeopardize their security clearance. So sometimes that's something to consider whether the individual's willing to take the medicine. Yeah, that too, fear of being medical boarded, which is possible. Jake, have you got some experience with folks on active duty and PTSD and medical boards? If you've got a microphone. I guess Jake does not have a microphone.
So lots of experience.
Jake, seeing how it is that half the people that you knew kind of came back like this, what thoughts do you have about this particular case that would enlighten your fellow student? Oh, he's still working on the microphone. Is Melody in here tonight? Because she's also had some experience with active duty troops. I don't see her in the lineup, but some of our students have had experience working with active duty individuals, so they can speak to some of the resistance. Yeah, that's true. Resistance would be possible.
And when you're thinking about medicine choices, really for anybody in particular, for the veteran population, is asking what side effect would you absolutely not be okay with.
Right.
And a lot of times they'll say, if I feel funny or if I feel tired, if it makes me feel less sharp, or I'm kind of slow to process, especially when many of them may already be experiencing those problems. We didn't really talk about a big part of this case yet. But yeah, Jake, like you're saying, I don't want to feel like I can't, like I'm not me or I'm not sharp. So say, okay, great. Well, then we won't do Paxil, and we probably won't do mirtazapine. Or I don't want my headaches to be worse, or sexual side effects.
Yeah, the sexual side effects are really pretty important too, because Prozac and Paxil both have a high probability of causing sexual side effects. So we're talking about this tonight because it's helpful to kind of talk through the thinking processes related to choosing what medication you can offer someone. So, Jake, what was a go-to drug that you saw for the folks who were being treated for this? Okay. For a short-term period of time, Ambien is not bad. One has to be cautious about is that it become every day, all day kind of a process. But Ambien initially to help people to get to sleep, particularly when they're sleep deprived, is not a bad choice. Generally speaking, though, you'll notice in most of the medication lineup, benzodiazepines are not included, and a lot of sertraline as well. Okay, thank you. So a lot of times what a prescriber uses is what they're comfortable and familiar with, as well as the side effect profile that the individual that they're treating will tolerate. So depending on the individual, they may or may not take the medicine. So you may have to go back to the drawing board. So any other comments on this particular thing about what you do with the prazosin? When would you increase the dose on that? Again, it's not FDA approved, but it has been shown to be helpful to combat veterans. It doesn't necessarily have efficacy for people who have PTSD that's not combat related. And unfortunately, recently there was another study done that looked at individuals who were stable with their PTSD, who on a double-blind study were tried on prazosin, and there was no difference between the placebo and prazosin. But with an individual like this, there is a potential for a lot of change. So to consider that the population that you're using the medication on is going to alter how the medication is going to respond for that person. So other comments on this case that you thought about as you were looking through it? What medicine you use? Go ahead.
I went back to this first slide just so that we could revisit a pretty important point in that second bullet.
That it was his second combat tour of duty. He'd just been injured in his 5th IED explosion that he had personally experienced in his 5-man team, that he was the only one who survived. Okay, so that is the other piece to this, Karen. Thank you. One would anticipate that, particularly if he was in the same vehicle as these other folks who suffered major injuries. The injury that he experienced was ruptured eardrums. So with the ruptured eardrums, that would speak to the shock wave that he was in, which probably did a considerable amount of damage, a shearing effect on his neurons, which, yeah, it could explain some of the aggression. It's hard to tell because PTSD by itself without the TBI has the potential of being aggressive. Were there other points on this, Simone, that you wanted to highlight?
No, we were going to segue the TBI into, because I think we're about to talk about, oops, this is not what we're about to talk about. What is this garbage? Get out of there.
Yeah.
Yeah, we don't need any of this. We don't need any of that. Because we were going to segue into into some more detail about TBI and treatment and things.
Right. So what we're talking about tonight is what makes PTSD different for individuals who've been in the military. And some of it has to do with the prolonged and ongoing stress that they're under for long periods of time. That being in a foreign country in the military, and this is pertaining to folks who are deployed many times, like in Alabama. The National Guard has been deployed a number of times, and folks who joined the National Guard didn't necessarily join with the idea they were going to do anything. Now, this is pre Iraqi war, and everything changed after the Iraqi war began. So that changed everything. So the stress of climate, diet, living arrangements in which people are living together with others, the stress of living in crowded, confined, highly structured environments, and the stress of combat, personal danger, danger to everyone else, and not being able to tell who is the enemy. Who's a threat, who's your friend, which I think anybody who's been reading the news has heard about. Individuals who pretend that they're part of a unit and they end up blowing them up because of philosophical differences from one group to another. Jake added, getting hit inside of a Bradley is particularly brutal. The pressure inside can be huge. So I appreciate you adding that part, and that contributes to this particular fellow's brain injury. Next slide, please. So continuing on with stressors in theater could be biochemical exposures, and particularly in Iraq, they had burn piles in which they were burning debris in the open air. Many soldiers were exposed to toxins of different levels of unknown kinds of toxins, dehydration, and never really being off duty. It's not like when you're working shifts that you can go home and it's out of sight, out of mind, because you're always on duty. Contact with family is interrupted. And this part here about seeing things one can never unsee. That what one is exposed to is unlike anything that they would have ever been exposed to in the United States. So we got heat and cold and nagging injuries. And then there's the issue of political decisions that drive chain of command decisions against personal decisions. So next slide, please. So redeployment, returning home in itself creates a stress because the folks that you're stationed with, that you're assigned to, the people that are in your team become family. So you have a mission, you have a purpose, you have a duty, you have function. When individuals return home, quite often what happens is they miss that sense of belonging, of having purpose, of being part of something bigger than themselves. And they experience separation anxiety. They have to turn their weapons back in. They say goodbye to their unit, to their buddies. And there's a sense of things being undone. Returning home, people want to know what happened. What did you do while you were over there? And oftentimes people don't necessarily want to talk about it. And they have to leave their military family to return home. Next slide, please. So differential diagnoses for PTSD, just to review, adjustment disorder, acute stress disorder, which that would require a time date on it. And for PTSD, to keep in mind that a person can have the exposure to the trauma and not exhibit symptomology for years, maybe as much as 20 years later. Anxiety disorders, obsessive compulsive disorder, MDD, personality disorders, dissociative disorders, conversion disorders, which we haven't covered yet, psychotic disorders, and TBI. So next slide, please. Risk factors for PTSD. Folks enter the military and usually have been screened for the ability to, number one, have graduated from high school and or have passed the GED, which eliminates a number of individuals who couldn't make it that far, who were either too disorganized or didn't have skills to exceed and graduate. But PTSD risk factors include having had earlier life traumas, particularly if there was mental health issues in the family, that they either were exposed to trauma as a child, experienced neglect, they lacked good social support of family or friends. Being a woman in the military also increases the risk factor, and experience other traumas early in life. So, in this top one, experience intense and long-lasting trauma, which is people who are exposed over and over again to trauma, such as sexual trauma and or military type trauma. So, next slide, please. So, with this, I'm encouraging you to go back to review CARLOT to consider criteria and risk factors for PTSD. On initial interview, to your process of and your job here is to discover and establish trust, not necessarily to know the details of what their trauma was, but to know about it, because you do not want to re-traumatize the individual. And I call that kicking over the rock, knowing full well there's something underneath of it, but because we are not trying to re-traumatize people, sometimes it's helpful to say, what was the worst experience you ever had, and letting them tell you what they wish to. Asking, again, particularly if you're working in a civilian environment, if have you ever served, is a good place, a good jump off place to discover if this person may have had military experience, which then could lead you into questions about traumatic brain injury. Sometimes in asking questions that may lead you to traumatic brain injury, maybe asking about were you involved in sports during high school, which football would certainly incur TBI for some people. With women, sports activities that occur TBI doesn't happen as frequently, but certainly if you get hit in the head with a softball that was thrown hard enough, you could occur TBI from that. So less likely, but we have to consider all the possibilities. Next slide, please. So looking at TBI-focused questions, the lead-off question is, have you had a head injury in which you were told you were out for a while? It's not terribly specific, but it asks about a head injury. It is not with judgment. It's not a good or bad thing. It is about discovering how long were you unconscious? Do you have any recall for the event and what followed? Because determining whether or not this is a mild or moderate type of TBI, the period of time that they're unconscious and their recall helps drive the decision making around that. And how many times an individual has had a head injury? Why would this be important? Anybody want to hazard a thought on that? How many times you've had a head injury? Why is this important? If anybody has a microphone, please use it. I would assume from the silence out there that you're thinking hard about writing something down, but so far nobody's written anything, but we're going to move on.
Augers are cumulative trauma, cumulative injury. The more times you get hit in the head, I imagine there's an accumulation of damage. I mean, I'm probably not using the right words, but
But it gets you in the right ballpark. You would anticipate the more times hit in the head, the more damage, the more neuronal death the individual would experience, setting them up perhaps for early development of what? What do you think the early development of a long-term exposure or frequent exposure to this kind of trauma would be?
Parkinson's?
That might be one thing, but I see somebody put dementia, and I was really going toward dementia. So, Jeannie, you got it on that one. So, gold star for you. That frequent trauma like this increases the risk that an individual is at risk for developing a dementia because of the frequent trauma, neuronal damage, and death that the shearing, particularly when they've had an explosive type of head trauma, such as with an IED, that shearing is going to cause micro tears, which probably a CAT scan may be able to pick up, but because you're going to be just doing a verbal assessment on this individual, it's helpful to think about the more head injuries they've had, the more likely they're going to have problems with cognition, with organization, perhaps with being even able to see their own behavior as being unusual, that they may not recognize that. Next slide, please. So TBI is considered the signature wound of the Iraq War because unlike other theaters in which many individuals died from gunshot wounds, this particular theater, the signature wound being a TBI secondary to these explosive devices that are used that are placed in odd locations, and many times they're unseen and come out of the blue. So the trauma is caused by a blasted pressure wave, which is something that Jake mentioned earlier, and the pressure increases and decreases and then increases again, which hence the eardrums rupturing, and the symptoms may overlap with PTSD. So the individual may or may not have other wounds. With someone who has had a concussion, they have no other body damage, they may feel like there's nothing wrong with me, just let me go back to work, let me go back to my unit. It is helpful to define it as mild TBI, which is loss of consciousness for less than 30 minutes, with amnesia of less than 24 hours post-trauma, to the moderate TBI, which the loss of consciousness is for more than 1 hour. So the 1 hour period of time, more than that defines a moderate amount of TBI, and the amnesia, post-traumatic amnesia, lasting more than 24 hours. So again, this is about the shearing of the axons and the microhemorrhaging in the frontal and temporal lobes. So next slide, please. So TBI primary symptoms, well, you would anticipate cognitive impairment. So you have memory disturbances, decreased attention span, language problems, which may be coming up with a word or forgetting how to pronounce them, apathy, and inability to tune out extraneous stimuli. So these folks might be overstimulated by the environment and become irritable and lash out. And they have a reduced efficiency of information processing, so that they're not processing well. You may ask them 2 or 3 questions in a row in rapid order, and they're not able to respond because they're still stuck on trying to figure out what the first question was. Physically, headaches are frequent. Dizziness and blurred vision may be a problem. And these are primary symptoms: irritability, anxiety, depression, fatigue, and sleep difficulties, and an inability by that person to recognize these problems, which is pretty much a cardinal symptom. The individual does not recognize these as problems. They just don't see it. Most of the time, the symptomology resolves within a 1-year period of time. But again, it really depends on the extent of the damage and how many times they've had head trauma. I've known of one fellow who had a severe head trauma secondary to a motorcycle accident, and he recovered well enough to be able to return to work. But he was very frequently anxious. He had problems with social engagement with other people, and worst of all, when he drank alcohol, which was a disinhibitor, he turned into another person. Translation: he was a kind, giggly kind of guy when he wasn't drinking, and when he was drinking, he was rageful and downright dangerous, in the senses that he'd lash out at other people. So most people, the symptoms resolve within 1 year, but some folks, depending on the degree of head injury, it never quite resolves or returns to normal. Next slide, please.
I can just kind of point out here, when you see, because you can map where the damage occurs to the symptoms. I'm sure y'all are looking at this and thinking memory disturbance. What structure specifically in the brain would be implicated in a memory disturbance?
Good point, Simone.
Yeah, Jake, excellent. The hippocampus. And the hippocampus is generally in the temporal lobe, which is kind of on the side and at the bottom. So if you're getting your head banged around, that's probably a part that might get banged around. Language. Where's language housed? Receptive language, kind of understanding. Yes, that is also in the temporal lobe. Yes, exactly. So kind of memory, language recognition, language processing. So you can imagine if I'm giving someone with traumatic brain injury really complicated instructions. So the first thing you do, you're going to take half of a pill for 3 days. And then if you're not having side effects, you'll take the whole pill, and you'll do that for about 3 weeks. And then at that point, you're going to go up to scratch. That is so many words. So just consider real long, complicated instructions, probably not the best idea, because they're going to have a hard time not only processing it, but then short term kind of storing it and knowing how to convert that into a plan. When you see decreased attention span, what part of the brain do you think about? Sustaining attention, kind of deliberate, sustained focus. Yeah, frontal lobe, prefrontal, sure. If you have different parts of the prefrontal cortex, like the dorsolateral prefrontal is, so you're talking about kind of on the top and to the side of the prefrontal. So generally your forehead, but a little more to the maybe to the top and lateral. So that's kind of what I just said, I guess. Planning, sustained attention, kind of working memory, something you would need to do serial sevens. That's why serial sevens, count back from 100, is so helpful to assess someone's kind of DLPFC functioning. Someone you may be concerned about TBI and want to screen for that. Short term, like recent memory, quick forgetting, rapid forgetting, things that you associate with Alzheimer's dementia. That's because you need the hippocampus to remember what you just talked about 10 minutes before. So that item recall, 3-item recall, can also be sensitive to TBI symptoms, that short-term memory loss that you can have there. Information processing, like Dr. Fogger was talking about, executive functioning, planning. I got to go to the store, and then I have to get this, and then I need to go to the bank, but I got to not spend too much money because there's only so much in my account. That sort of executive functioning, planning, forecasting of consequences, that's all DLPFC kinds of things. But then you have this irritable impulsivity, trouble with disinhibition. That's another part of your frontal cortex, but that's a little closer to your eyeballs, kind of orbital frontal. That's involved in impulse control. If that gets damaged, then you have people who might get in bar fights or spend too much money or talk back to the boss and then think, oh gosh, I shouldn't have done that. But they have difficulty kind of with top-down control of, oh, I'm mad and I want to tell you off. I probably shouldn't do that. Well, if the part of your brain that allows you to not do those things, to inhibit that response, if that's damaged, well, you get in all sorts of relationship issues like this fella. Not necessarily for that. We didn't say in the case. And another kind of prefrontal cortical area is involved in emotion processing and incorporating kind of feelings, which is lower structures, but trying to incorporate your emotional state into decision making, and also trying to kind of express emotions appropriately, or even express an emotion to a degree that is appropriate to the setting, understanding other people's emotional information, being able to navigate a sad situation, a frustrated situation, that will be damaged for these folks as well. So you can understand how, in some ways, emotionally charged in situations, things really go off the rails, and maybe why being around other people could be anxiety provoking too, because you're having to read signals and process what people are saying, which might be difficult, how people are feeling, which might be difficult for you. So that may just add to why it's just easier to not be around people, because there's all this information that's difficult to process. So when you map the parts of the brain that gets damaged to the symptoms, it makes sense that you see the symptoms that you do. And it can be helpful and important to ask, have you had a head injury? And then do these real brief screens for short-term memory and working memory and things. So, it's not hard to do house, ball, car, and then ask the person in 5 minutes if they can tell you back what that was. You may identify somebody who needs to be referred for more formal neurotesting or a TBI clinic or something like that.
So using a mini cog, which essentially would be the 3-word recall, and then draw a clock, which is not necessarily related to the TBI, but at least it'll give you an idea of their thinking and spatial processing.
Sure, and then the serial 7s, because that's an ongoing, have to maintain attention and tune out what you don't. Tune out distractions, but also maintain focus on this task and remembering the rules, like what am I supposed to subtract and what number was I just on? For people who don't have difficulty with that, it's kind of easy. But that's because we're able to rely on intact neurological networks talking to each other appropriately. So, but that was it.
Well, that's true. And with this population, you would anticipate that because they had graduated from high school, that they were capable of doing the subtraction of the serial 7s. Some individuals have not made it very far through school, and if they only made it through the 6th grade, which I've encountered some folks like that who, for various reasons, never finished beyond that, they may or may not have the capacity to have ever done serial 7s. So sometimes it's part of the screening process is about their educational experience. The piece of this that is similar to the PTSD has to do with also the effect on the hippocampus and people's ability to recall and remember things. So both TBI and PTSD are going to affect the hippocampus and the limbic system in some ways, but in different ways. But at the same point, those are some of the overlaps that you might experience. So next slide. So in review of some of the medications for PTSD, we've got SSRIs, and we're looking at symptom reduction. And with PTSD, it's helpful to have target symptoms that you're looking at assessing initially and then reducing. And SSRIs are better than placebo, which is helpful to know, but with PTSD, they don't always have good effect. Having a target that you're aiming for, that they may sleep better, that they have improved mood and decreased irritability, that gives you a focus for what you're looking for, other than I hope that you're feeling better with your PTSD. It's too vague and non-specific. So you want specific targets for the medication. It may take up to 6 weeks to reach therapeutic blood levels. And again, with the side effects on that, security clearances, sexual side effects, as well as the stigma of having a mental illness and being on medication, which individuals may choose to avoid. So pharmacological interventions are effective, but the magnitude of effect is small. For symptom reduction, if there is extreme irritability, you may look at mood stabilizers, such as maybe some Depakote, particularly if there's volatility. Some folks look at atypical antipsychotics to help with some of this mood lability. It just really depends on the population. If there's civilian population, you've got more movement because, again, with the security clearance, there are some things that you don't want to do, because once you start down that road, the individual may be boarded out because of treatment choices. So something to keep in mind when you're dealing with active duty individuals. They're going to be real conscious of what medication they can take if they've got a security clearance. But some medications, some medications used commonly in psychiatry are disallowed for people to have certain security clearances. So next slide, please.
And you're mentioning too how earlier sleep is so important. To just kind of have a running list in your head. There's no, I mean, you're really just trying to match a med with the symptoms here, but think about what medicines might be good to augment Effexor or sertraline, because you don't expect either of those medicines to have a significant impact, at least not early on sleep. Regulating serotonergic transmission can help sleep, but it's not a quick fix. So, think about what medicines like the mood stabilizers, those are very sedating. They're really antihistaminic. They can be good augmenting for sleep. Things like, Seroquel in particular. Some folks will do Risperdal at night to help with not only sleep but mood stabilization too. Another thing, you have your trazodone, you have your mirtazapine. Even though mirtazapine can increase nightmares sometimes, when you think about mirtazapine's mechanism of action, it can actually be pro-noradrenergic, and you don't want that, because that's what contributes to the hyperarousal and the nightmare, the re-experiencing. So mirtazapine works great for some people, and other folks, they think, oh my God, my nightmares got so much worse. But people will say that about trazodone as well, maybe not as much. Tricyclic antidepressants, amitriptyline, nortriptyline, that may be helpful. But just keep in mind the side effects that you may be, just think about the side effects that may come with those medicines. People, like we talked about earlier, I think Jake said, folks who don't want to feel slowed down the next day. Be careful with your trazodone dosing, because if it's real high, people have that hangover. They'll swear off that medicine forever. And in particular, when you're working with someone with PTSD and a TBI, they may maintain kind of this disinhibited mood, sort of volatile moods, being easily distractible, those kinds of things that the SSRIs, SNRIs don't touch. So it can really be helpful to add mood stabilizers for people with traumatic brain injury, especially when you think about, damage tends to cause neurotoxicity, which gets glutamate up, which gets cells overly excited, almost it's not the same thing as seizures, but you can see seizures a lot after head injuries. Well, that's probably because GABA has been enhanced and released just by the damage and the inflammation that's there. So things like Lamictal can be really helpful. Lamictal can enhance GABA, which slows glutamate down, generally calming the brain down without doing what benzos would do, which is really disinhibit people who are having trouble with inhibition anyway. So definitely consider mood stabilizers, Lamictal, Depakote in particular, when you're working with folks with PTSD, that the SSRIs just don't seem to address some of those behavioral kind of issues. This goes right into what we were just talking about, the excess noradrenergic output, which is being kind of maintained. So if you can slow things down without disinhibiting the person, without shutting down prefrontal structures that may already be inhibited because of damage, because benzo is just going to make everything work not as well. Your amygdala won't work as well, so you won't be as amped up, but your frontal cortex won't work as well either. You don't want that combo. So serotonin has a inhibiting effect in the amygdala. It has an inhibiting effect on noradrenergic neurons. That 5-HT, the 5-HT3 receptor tells GABA to pick it up and turn noradrenergic neurons off. That's how serotonin enhancing drugs improve panic and improve anxiety, because it slows the activity. It's not a exciting neurotransmitter when it comes to panic. It's a calming through a roundabout way by reducing noradrenergic output. That's a good thing. So we have to try to get at reducing arousal without just blanket turning everything off, including our higher control mechanisms like your orbital frontal cortex and your dorsolateral prefrontal cortex. So that's really why we got to come at it with these other ways. And when you combine it with therapy, people can get much better, much sooner. You think about the metabolic and cardiovascular risks also of people having excess blood sugar a lot and high blood pressure a lot and all these things. So if we can combination medications, the right medicines, assess for TBI, make sure you're addressing that appropriately in addition to PTSD. We got to take a multimodal approach here. Breathing exercises, if you force flowed respiration, that will increase parasympathetic tone, which will reduce sympathetic tone, which is in excess for people with trauma-related disorders. We talked about prazosin a good bit. It really directly inhibits the pathways that cause the reactivation of the memories and the reactivation of that panic response. So that's why it's helpful. And really, you would dose that until the side effects don't outweigh you would dose it until the side effects are greater than the benefit that you get from it, which can vary widely from some people that love 1 milligram, some people need 10 or 12.
That's true, because some folks respond well to 2 milligrams.
Mm-hmm.
And if you're responding well and they don't have any particular side effects, and the person feels like it's significantly made a difference in their sleep, and sometimes you can just leave things alone. There's no point in really pushing the dose to if the patient feels like the side effects are at a point that they're able to manage them. So we've almost run out of time, if we haven't run out of time.
I think it's 8:03.
What we have left in the rest of this slide deck primarily is focusing on alternative treatments and methods of treating PTSD that are evidence-based. Again, I refer to that article that's in your reading that go through the different types of evidence-based therapies, and the slide presentation for the rest of this here out kind of just reviews those and what your options are. Many times individuals who come to therapy either because their family members push them because they can't live with them anymore, or because they recognize themselves that they can't continue as they are. Suicidal thinking is something to assess for sure, because anybody who is living constantly with this type of invasive interruptive thinking over and over again, where they're re-experiencing this kind of trauma to this degree, it's really difficult to live with that day in and day out. So assessing for suicidal ideation is really important, particularly in the veteran population where suicide risk is pretty high, precisely for this issue. And I mentioned it last time that with some of this trauma, people don't want to share because they're afraid that in the sharing, they're going to traumatize you. So as you're listening to people, be aware of how you're responding to them and respond appropriately, but keep your reactivity down so that they don't feel like they are overexposing you to their trauma. So what have we got left here, Simone?
We've got really just discussion of therapies.
I think that the article and the rest of the slide presentation just basically could be used as a good note-taking device. We've run out of time with this, and again, as I said, I think that the article talks about the therapies that are optional for this. Most of them, the CPT, cognitive processes training, and the exposure therapy are manualized, requiring that the individual come in for a series of therapies, which means that they have to come in biweekly or weekly. And if you consider how difficult that is to complete a series of these visits, many times veterans in particular never finish the therapy sessions because they can't get in, or don't want to get in, or don't want to kind of be re-exposed to what they anticipate is going to be problematic. So read over what these therapies are. I think that if you have an opportunity to sit in on therapy, it's really helpful to understand that therapy really does make a difference. The individual needs to be able to say, I think that I could use some opportunities to talk about this. And whether a person chooses medication, whether they think it's going to work or not, really also has to be elicited. What do they think is going to work for them? So symptom reduction is a good goal, and to essentially assess the individual about what it is that they're willing to accept and whether they're willing to go the course. None of these therapies take 1 or 2 sessions. Most of them are often weeks to help resolve some of these underlying issues. And again, they're not going to go completely away. The role of this is to essentially get them to a point that they can function in the world and be successful. So that's about as far as I want to go with this, because there's at least another 25 slides, and it's pretty self-explanatory. I do appreciate everybody coming tonight, and Simone, I appreciate you bringing your neuro anatomy to kind of help people think about this as it relates to the neuroanatomy of the brain. PTSD and traumatic brain injury are directly related to changes in the structure of the brain, and they manifest themselves in multiple ways. Anything else? Somebody wrote here.
The take-home point, I guess, is from this lecture is to be very familiar and be able to pick out diagnostic criteria of PTSD, what are the FDA-indicated medications, and then all the adjunctive therapies, treatments, medicines you need to add to it. And also assessing for TBI, what would that look like for somebody, and
we can study right now.
What would that look like in a person? How would you assess for it? How might you ask about it? What medications might be helpful? Jake had a comment, some feel lost after redeployment.
I think in particular, this speaks to one of Viktor Frankl's therapies, which looks at finding purpose in life. And in the process of assessing individuals, what is their life purpose? Do they have one? And without a purpose, what's the point of being? So helping people become involved in having a purpose is part of the process of returning to the life of the living. What is your purpose in helping the individual have a purpose? That's kind of where many times animal therapy comes in, where then the individual has a purpose, which is to take care of their pet. And it gives them some ability to connect with another thing when maybe they can't connect with people. So last word, Simone?
That's it. That's all.
All right. Well, thank you everybody for coming.
Absolutely.
We'll see you all next week.
All right. Y'all have a good evening. And as always, please email us with any questions that you might have.